Hi everyone, welcome to our webinar today and thank you very much for joining us. Our webinar today is called Human Factors Contributions to Healthcare in Canada and Around the World, Everything You Wanted to Know But Didn't. Our special guest speakers for the call are Dr. Kathy Momtahan, who is an adjunct professor with the University of Waterloo Systems Design Engineering and a Healthcare Human Factors Network lead. We also have Dr. Gianni D'Egidio, who is an internal medicine physician and ICU intensivist with the Ottawa Hospital. I'm going to be your moderator for this webinar, and my name is Jason Thompson. I'm a communications officer with the Canadian Patient Safety Institute. Before we get started, I'd just like to introduce you to our Human Factors Network. The Canadian Patient Safety Institute, through the Shift to Safety program, has teamed up with the Canadian Human Factors and Healthcare Network to provide human factors information to healthcare organizations and professionals who work in healthcare and to add their existing knowledge base related to quality and patient safety. This is the first in a series of Human Factors webinars that we have got scheduled. Our next call is set for October 18th and registration is currently open. So if you head to our website, patientsafetyinstitute.ca, you'll be able to register for it there. The call on the 18th is called When Being Present Isn't Enough, Improving Patient Safety Through Situational Awareness. It will feature Dr. Lisa Calder from the Canadian Medical Protective Association and Dr. George Mastoris from the Ottawa Hospital. We also have future calls on the Human Factors series scheduled for November 15th and December 13th. If you visit our website, patientsafetyinstitute.ca, you'll be able to subscribe to our mailouts, which includes a monthly events calendar sent to you that gives you a look at events happening at CPSI and some of our partners in the coming months. You can also follow us on Twitter at @patient_safety. Before I pass the ball over to our presenters, I'll just walk through the chat and Q&A process. If throughout the course of the presentation you have any questions or comments, please feel free to send them to us in the chat box or the Q&A section. We will collect them and we'll have time for some Q&A once both presentations have concluded. So with that, I'm going to pass it over to Dr. Kathy Momtahan. Kathy spent the first 10 years of her career as a critical care nurse and then returned to school, completing a PhD in experimental psychology, focusing on human factors in healthcare. She worked as a human factors specialist in the high-tech industry for many years and then as a research leader at the University of Ottawa Heart Institute for 5 years and at the Ottawa Hospital for 9 years. She now does human factors consulting, organizing this Human Factors Network activity, and is finishing a piece of research on multidisciplinary handover. She also teaches a course she developed on workflow, human factors, and patient safety in Algonquin College's new postgrad digital health certificate program. Welcome to the call, Kathy. The floor is yours.
Thank you. Welcome, everybody, and thank you for joining us. And I'd like to thank the CPSI for supporting this activity, and in particular, Gina and Tricia have been wonderful. Next slide, please. Okay, so I started out looking at auditory warning signals in the operating room in the ICU, and there may even be some people here still at the Ottawa Hospital that remembers me doing a pilot with some really bad analog equipment. Luckily for me, for this particular study, I had access to very good digital equipment, and there was also a team in Montreal who had masking software that I used. So I'm not going to go through this abstract. It's available online in PubMed. The interesting thing to me, though, is that I have not looked at auditory alarms for many, many years seriously, other than in passing, but now there seems to be a whole new area of research called alarm fatigue. Okay, so for those of you who are not familiar with the area of human factors engineering and psychology, it's a scientific discipline concerned with the understanding of interactions among humans and other elements of a system, and the profession that applies theory, principles, data, and other methods to design in order to optimize human well-being and overall system performance. So there are many schematics around that describe sort of what human factors in general is about. This is mine. It's very simplistic compared to many others. but you will get the general impression. You have the environment that we're all working in, and for many of us that is the hospital environment, but other healthcare environments as well, that has an organizational structure, work systems, business processes, and work-related stressors. And in that environment, we have us humans, which also includes the patients and their families, and technology that we're all using. And in terms of the humans, we have to think about the cognitive processes, perceptual processes, our physiology, motor processes, affective processes, et cetera. And in that structure, we have many capabilities, but also some limitations. And then we also need to think about training and teamwork. On the technology side, we have computer-based systems, and that's pretty much everything now. Various devices like infusion pumps, networks, and the design of all this technology in our environment. So what do healthcare professionals already know about human factors? Well, I think by now most healthcare professionals that I interact with have heard of human factors engineering and psychology in the context of patient safety, human error, James Reason's Swiss cheese model, the design of medical technologies, the design and use of electronic health records, usability testing, et cetera. Both the CPSI and the WHO have modules on human factors, as do other groups. And now that many clinicians already know about the basics of human factors, what else is there to know? So I think that we've moved beyond human factors 101 in healthcare. I think that many people know the basics. But what we don't know is where do we go from the basics? And how do we get help with more sophisticated human factors work? And although the title of this talk is pretty grandiose and you are not in 10 minutes going to learn everything you want to know about human factors, we did start a network of human factors specialists around the country so that we could do some wider spread of knowledge translation activities with regards to human factors, and also to be able to let people know where they can get help if they feel that they need some human factors help with their patient safety initiatives. So this introduction is meant to celebrate past successes with an emphasis on Canadian contributions to the science of human factors, and to provide an overview of human factors applied in clinical practice today, as well as ongoing research. Like I said, it's not going to be comprehensive, but you will definitely get a taste. So why will we always need to be vigilant about human factors in healthcare? Well, I think the human factors condition is relatively stable, although amazing. It does change over time from birth to death. But healthcare technologies continue to grow at a fast pace. And the next 4 questions, for those of you who are quite young, these questions will not make any sense to you, but I expect that there are at least some people that are closer to my age that will remember some of this stuff. So, do you remember what it was like when you had to go to the library to look something up? When you spent time counting drips on an intravenous infusion? Being social meant going out somewhere with people? And you hadn't even thought about working with a robot. All of these are now reasonably standard, with possibly with the exception of people working with robots yet. So why is healthcare technology still so bad? And this is an article that I pulled up from the New York Times by Robert Walker, who's a physician and a well-known patient safety advocate and author. And I actually use his book in my course at Algonquin. So at his own hospital, he's describing, what happens in terms of having glitches in systems still, and why is this? And part of it is that technology is continually changing, and we have to be wary of all the places where patient safety can be compromised. So in terms of alerts, there is definitely a lot of literature around alerts that there's too many, they're not the right type. People like auditory alarms, people turn them off because they're inundated with information that they feel is not information that they need. And then sometimes you miss the information that you really need. So I'm not going to read this, you'll have, have access to the slides, but this is just an example of why we always have to be vigilant about the technology and the systems that we work in. So about 2 to 3 years ago, I started thinking about the fact that people keep asking me, how do I get to know more about human factors? And because I've worked with many different people around the country and had contact with others in terms of the human factors work that they do, I thought that it might be useful to have a network where people could look and see who's doing human factors work, sort of what kind of work is being done, et cetera. So we formed this human factors network, and the purpose is to provide human factors expertise to healthcare organizations through consultation, knowledge transfer, and exchange activities, and the promotion of partnerships between healthcare organizations, industry, and academic institutions to promote delivery of safer, more effective care to patients. And I'd like to say that I also think that it's important to support students that are currently going through human factors programs and giving them opportunities to apply their human factors expertise in healthcare. So members include engineers and psychologists, information technology experts, designers, and clinicians who are involved in patient safety with a human factors focus. Many of the network members have worked on projects together, have supervised graduate students together, and have otherwise educated various people regarding human factors. So our network information is now online. You'll be able to see who's currently part of the network. That is by no means a closed club. If people are doing human factors work and they want to join the network, they just need to contact us. And it's not, it doesn't include some of the groups that I already know about as well. But I also wanted to mention that other than our current human factors network members, there's some champions that have done work and whose literature we often reference and refer to, and this is just an example, but Dr. Prosperity's an emergentologist in Halifax. He's done a lot of work in clinical decision-making, cognitive errors, and he was the lead for the Halifax series of patient safety conferences. And so his work is definitely something that I teach students. Dr. Sojanya has worked in medical error, the area of medical error and patient safety for a long time as well. He has been very instrumental in things like WebM&M rounds, which I highly recommend, actually. WebM&M, the scenarios and the commentaries are very useful to gaining an understanding of some of the human factors issues that people submit. And Dr. Etchels, as well, in Toronto, has worked on medical errors and has been a patient safety leader who often has a focus in terms of human factors. So these are some links to where there's information on human factors, clinical human factors around the world. By no means is this, inclusive of every piece of information that you'll ever find around the world. And there's also a lot of private human factors consulting companies that do human factors work for people as well. Okay, so that's it for me, and I'm going to hand it over to Gianni. And Gianni is an ICU intensivist that was mentioned here at TOH who did his human factors engineering master's in Toronto.
Hi, everyone. Thank you so much for inviting me to talk. Exactly as Kathy mentioned, I'm an intensivist and internist here at the hospital. Part of my research has looked at many different aspects of healthcare, but in particular cardiac arrest. And before we get into the talk, I will fully disclose that I think we can do a way better job at cardiac arrest, and I think there's a variety of reasons. Not to mention the stress level that's associated with it and the acuity of it, but there's a variety of reasons in terms of communication, team organization, and as you see here, the project that I've recently worked on has to do with the design of defibrillators. I think we can provide a lot more timely intervention to people, and I think one of the major reasons that we fail to do this is actually due to defibrillators, so I'll get into this. So all funding for this project was provided by the University of Ottawa Department of Medicine Patient Quality and Safety Research Grant and the Ottawa Hospital Division of Critical Care. It was $5,000 each to do this study, and actually we actually didn't even use all that money, so it's We still have some. If we end up publishing, it'd be fantastic. So delayed defibrillation in the United States numbers, roughly about 75,000 to 150,000 patients a year suffer an in-hospital cardiac arrest, secondary to a ventricular tachyarrhythmia. And obviously, people undergo attempted cardiopulmonary resuscitation. The only rhythm-specific therapy proven to increase survival to hospital discharge is timely defibrillation. And if you look at guidelines that are out there, the American Heart Association suggests that you should defibrillate people within 2 minutes of recognition of cardiac arrest. And just remember, in hospital settings, we basically have, I'll say, 2 types of monitored settings. Either you're unmonitored, so you're on a regular ward bed with no regular or minute-to-minute or second-to-second recording of your vital signs, or you're in a monitored setting like the intensive care unit, the emergency department, what we call the acute monitoring areas, so areas that actually are capable of monitoring. So what's the problem with delayed defibrillation? So patients who experience delayed defibrillation are less likely to survive, bottom line. If they have a shockable rhythm and they don't receive timely defibrillation, studies have shown they're less likely to survive. So roughly 22% when defibrillation was delayed versus 39% when defibrillation was not delayed. So quite a stark difference in mortality. And even amongst those who survive, you have a lower likelihood of having no major disabilities if you receive timely defibrillation. Sorry, I've repeated the same sentence there. So the National Registry of Cardiopulmonary Resuscitation, CPR, basically says that delayed defibrillation occurs in more than 30% of this patient population. And in their study, they quote an average time to defibrillation was approximately 1 minute, which is, frankly speaking, excellent. We have some internal data here at the Ottawa Hospital that it takes roughly about 8 minutes in a critical care setting. And now this does not include our cardiac institute, which is completely different. And it also takes roughly 11 minutes on the medical ward to receive defibrillation. And as I mentioned earlier, there are a multitude of factors that go into this. What I'll do is I'll take about a minute or so and describe the makeup of a cardiac arrest team, or what we call our Code Blue team. So I'm an attending physician, and on my team I would have many residents and med students. And when I'm on the internal medicine service, that service is responsible for providing our Code Blue team and responding to Code Blues. So that team is made up of 1 senior medicine resident and then 3 to 4 junior medical residents. Now, junior medical residents could have a background in orthopedics, in anesthesia, in medicine, or something like ophthalmology. So their knowledge base and their experience with cardiac arrest can be quite limited. Occasionally, if there is a attending physician nearby or one who's very experienced, like myself, who's participated in many of these, we may run the Code Blue. But generally speaking, 24 hours a day, the cardiac arrest pager is carried by a senior medicine resident and run by that senior medicine resident. There will also be nurses involved. There may be bedside nurses that can get involved in cardiac arrest, and there's also ICU nurses that will respond to the Code Blue. So there's actually very limited data available regarding the system-related factors and patient-related factors that are associated with higher probability of delayed defibrillation. And just based on anecdotal experience, mainly myself, hypothesized that flaws in defibrillator design would contribute to a delay in timely defibrillation. And we planned on studying this, and we studied it by using our sim center. And basically, we use high-fidelity usability testing and asked for volunteers, all medicine residents, and I'll get into the details of this a little bit later on. But just to take a little aside as well, the reason I hypothesized this, as someone who's probably been part of, I would say, over probably 100 cardiac arrests in my limited career, I've noticed time and time again that there's been errors associated with the use of the defibrillator. And I'll get into these because they were confirmed in our study. So usability testing, for those of you that don't know, is a technique in which users interact with the product under a controlled condition, and behavioral data or other types of data are collected. And as Kathy had mentioned earlier, this information is then applied better to understand human performance capabilities, human performance limitations, and then more importantly, how product design can be modified to meet these needs. And obviously, it's thought to be an essential component of safety engineering and other fields, but usability testing in medicine, for the most part, has been reported to be underutilized. So our methods and design was both a qualitative and quantitative prospective usability study evaluating the use of a manual mode defibrillator in a simulated hospital environment. The study protocol is approved by our ethics board. So just to give you an idea of what the Ottawa Hospital is like, it's an academic quaternary care regional referral center. We have over 1,100 inpatient beds. It's operated in conjunction with the University of Ottawa, and the University of Ottawa Skills Center is the largest medical simulation center in Canada. That's what I'm told. I mean, maybe the other institutions out there will argue that, but it is quite large. So simulation was conducted in the high-fidelity clinical exam room, and tasks were performed using a full-size human patient simulator. And you can see what our sort of sim center looks like. Depending on the level of interaction, we can program our mannequins to basically do anything. So that's just a quick snapshot of what our sim rooms look like. This is the mannequin we use in our experiments, and we can basically dial in any sort of arrhythmia we'd like, and the response to defibrillation or cardioversion. So this is our defibrillators, and I'll disclose that these defibrillators are getting replaced. The whole fleet is due to be replaced, and we are in the process of replacing them, not because of any of the work that I've done, but because they're reaching their lifespan. But this is what we use here, and we'll go through it in a little bit of detail as I proceed. So what we did was we had 22 internal medicine residents, all postgraduate year 1 through 3, and these are all residents that would be part of the Code Blue team. All of our participants were certified in ACLS and have completed their ACLS training within the preceding 12 months. So every resident every year has to go through this training. And not only are they provided with a formal ACLS training, but they're also put through simulation sessions with myself, actually, on not particularly cardiac arrest, but resuscitating critically ill patients. So senior residents are considered PGY 2 and 3 residents, and there are cardiac arrest team leaders. And as I mentioned, the junior residents, PGY 1s, are members of the cardiac arrest team as well. So basically what we asked the participants to do was basically perform 2 simulated tasks, typical of in-hospital cardiac arrest: defibrillation, so attach the defibrillator device to the patient, perform a rhythm check, confirm the presence of ventricular fibrillation, and then deliver 1 basically shot. And then we asked them in follow-up a few minutes later to perform a synchronized cardioversion. And I'll explain why we do this a little bit later on, but the main point was the defibrillation, and we'll focus in on that for the time being. Our primary outcomes were time to defibrillation and the proportion of participants able to deliver a defibrillation within 2 minutes. And then our secondary outcomes were objective observer evaluations by myself and the resident lead on this project, Dr. Mark Reason, and participants' perceived usability of the manual mode defibrillator, and then a thematically coded qualitative participant feedback on usability. So under the secondary outcomes, subsections 2 and 3, we actually adapted from the only previous study that we could find regarding defibrillator use. And the only previous study that was available was a study looking at defibrillator use in paramedics. And because that was the only study, we figured that we would steal from them basically and use some of their methods. So time to defibrillation. Average time to defibrillation was 4 minutes and 21 seconds, give or take 138 seconds, which, as mentioned earlier, is not meeting the recommended 2-minute guideline. And average time to defibrillation for senior trainees was similar to that of the group as a whole, and was at 3 minutes and 56 seconds. only 9.1% of our participants were able to perform a simulated defibrillation within 2 minutes. And the average time to synchronized cardioversion was 1 minute and 55 seconds. And I'll explain why that time was different. But bottom line, I think, is because people had recently performed the task and could remember what to do exactly. And we'll discuss this in the discussion aspect a little bit later on. But you can see the first time that they had to defibrillate someone, it took them 4 minutes. So what were the issues with defibrillation? So based on our observations, the ability to turn on the defibrillator was only 27% of people found that difficult. However, if you look at the next two sort of core functions, ability to attach the defibrillator pad and ability to select an appropriate display were quite difficult. The majority of people had difficulty doing that, and I'll explain that a little bit later on. Once everything was completed, the ability to actually deliver a shock was quite easy, and well, most people, I shouldn't say easy, most people were able to do it. And then the ability to deliver a synchronized cardioversion was also, most people were able to complete. So the issue of attaching defibrillator pads and selecting the appropriate display, I'll just back up here. I'll explain it right now. Our defibrillators come, the preset of the defibrillator is that from the defibrillator to the patient, there's two things that you can use. You can use defibrillator pads or you can use the paddles. The pads are basically sticky pads that you can place on the chest and the back. And the paddles are what you see like in the movies where, in the olden days, people used to rub them together, put some gel on, and then apply a shock. And you have either option when it comes to defibrillation or synchronized cardioversion. For whatever reason, the majority of residents tend to favor the defibrillator pads. And the reason I suspect that is it allows you more space and you don't have to be directly over top of the patient and your hands are free. So most residents will go towards doing that. The default of the defibrillator is that the cable is actually attached to a battery at the start. So the user has to disconnect from the battery and then apply either the pads or the paddles to the patient. Most people think the paddles are automatically attached to the defibrillator, and I've seen many, many times people actually try to deliver shocks with the paddles, and it's not even connected to the machine. And that's because of the default sort of mode that the defibrillator is in. What also happens is after you apply the pads or the paddles, the defibrillator requires you to actually dial in the appropriate display. And you have to be able to select that on the defibrillator. If you don't select it, you won't be able to deliver a shock. And most residents forget this and have difficulty doing it. The other issues as well is as you can see there, is the ability to identify the adapter cable and hook up an adapter cable, and then the ability to actually physically toggle the cable locking mechanism. And I'll explain those a little bit later. Actually, maybe I'll just skip ahead here if I can get a picture of it, actually. Go back here. I'll explain it now. The adapter cable is found on the cart and needs to be connected to where that battery is. And most people don't know where to connect that because there's actually 3 or 4 different ports that look like you can connect it to. And then once you have it appropriately applied that adapter cable, then you have to put it into the cable locking mechanism. And I'll show you on pictures later on, this green little locking mechanism is located at the bottom of the defibrillator underneath a handle. You can imagine that if you've got fat fingers like myself, and I know you probably can't see them, trying to actually detach the cables and attach them is actually quite difficult. And you can imagine they're under somewhat stress during a simulation study, but in an actual code blue, you're under profound amounts of distress, and it's actually quite difficult to do unless you've done it many times. So we stole this post-exposure questionnaire from that previous study that I was talking about. You can see that the users, how would you rate the ease of difficulty in completing the task? And from a scale of 1 to 9, 1 being very difficult, 9 being very easy, the majority of people found it actually quite difficult. And then if you scroll down to the bottom of that table, how would you rate this overall usability of this defibrillator? It's kind of in the middle. It's not great. We would strive for a defibrillator being a very easy aspect of a cardiac arrest. And as you can see there, it's not, and that's one of the issues that we have. One of my thoughts is that I think you can actually probably defibrillate someone faster with an AED, so an automatic external defibrillator, than a manual mode defibrillator. I've used AEDs before, and they are actually quite foolproof compared to the machines that we have. So moving along, qualitative participant feedback was analyzed and then grouped according to theme. And predominantly what their feedback focused in on was the process of attaching the hands-free defibrillator pads, as I mentioned earlier. All 22 participants commented upon at least one aspect of this core function. And some of the descriptors they used was unintuitive, inconvenient, and awkward. So in terms of discussion, and I've already mentioned a few things here, the participants in our study are educated predominantly. There are all educated and senior trainees with high degree of familiarity with the defibrillator and ACLS protocol. But despite this, the average time to defibrillation was greater than 2 times that was recommended. It appears likely that the delay in defibrillation is least explained by poor defibrillator design and lack of usability, especially under a stressful situation. And I continually see this when I'm part of Code Blue, that even the most expert of users continue to make errors, and I'm not going to go into these aspects today. It's beyond the scope of this talk. But my argument is if the defibrillator was designed better, I think we could cut down the time significantly. So in terms of my, I guess I'll call myself an expert observer of evaluation, the 2 biggest things that I found that residents continually had difficulty with, and what people have difficulty in real life is attaching the hands-free defibrillator pads and then not selecting the appropriate display for defibrillation. So as I mentioned earlier, if you can see my mouse on the screen, this is the cable locking mechanism, and as I explained, it's underneath this handle. And what most defibrillators, what most floors do on defibrillators is they actually Velcro or tie this defibrillator on top of the cart. So you can imagine if this thing is not mobile and is secured to this cart in some sort of fashion, trying to get in there and actually access that and attach a cable to there is incredibly, incredibly difficult. So these are the hands-free defibrillator pads on the left, and you can see that there's the adapter cable here. Most people cannot find this mechanism here to attach it to. It's hidden somewhere, or they're not certain of where to attach it, and you'll see people take this and try to plug it in here or in the back. And that's where, as mentioned, the majority of people have difficulty. Here's the cable locking mechanism, just a closer view of it, and you can see what I'm talking about there, I hope. So the default display was the other major, I guess, issue that users had. And as mentioned, the display information comes from multiple inputs, including ECG leads, the hands-free defibrillator, and the paddles. So you actually have to select which one you would like. The default display is actually of ECG lead 2, and more times than not, people are actually not hooked up to the ECG leads. So when using either the hands-free defibrillator pads or the handheld paddles, the input must be changed manually so they can actually be used. So what we would actually suggest, this is easier said than done, but modification of future defibrillator design may result in more timely defibrillation. Obviously, I cannot prove that right now. But engineering potentially a hands-free defibrillator as a single component, I think, would be fantastic, much like in most AEDs. Modifying the default display so it's automatically set to whatever you decide to use, whether it's the hands-free pads or the paddles, and then relocating the cable locking mechanism to a more accessible location is what our suggestions would be regarding this particular defibrillator. So in terms of critique of our study, in terms of validity, it's largely dependent upon obtaining behavioral data from actual users of the device, which is a positive, and we attempted to replicate many of the environmental factors that residents would face in real life. The things that were most similar to a true cardiac arrest were, honestly, we used the exact same defibrillator. We the exact same carts that you would find on any floor, but there was no other team environment. It was just the resident there with the defibrillator and myself and Dr. Reason observing them. Now, physicians are responsible for defibrillator use during cardiopulmonary resuscitation. That being said, in our institution as well, if an ICU nurse arrives promptly, usually they will administer defibrillation as well. Our ICU nurses or our CCU nurses are well-versed in the defibrillators and do not have this issue. If you see them perform, and it's getting to what I was alluding to earlier, but if you know this defibrillator inside out, there's no issues with your performance. It's for those people that don't do cardiac arrests all the time and who are not exposed to it on a, let's say, weekly or monthly basis. Cardiac arrests in general, their incidence has decreased for a variety of reasons. So part of our argument is, as well, is that our senior medicine residents, some of them in their entire years of training may not get exposed to a cardiac arrest. So they're expected to use this machine that they infrequently are exposed to and use and have to try to remember how to use it. So it can be quite difficult. So it remains somewhat unclear as to why so many of our participants were unable to complete a simulated defibrillation within 2 minutes. We would expect the defibrillation to occur more rapidly in a simulated environment. There is definitely a role for improved training and education. So as you saw when we asked them to do the second task, the synchronized cardioversion, they were able to do that within 2 minutes. And there's obviously a component of learning and recency that they can apply to be more effective. But the crucial question is, how often should we refresh our trainees? And the logistics of that are quite difficult. We have about 60 or 70 trainees. Coordinating their schedules is quite difficult, and pulling them out of clinical duties to provide refresher courses on defibrillation can be quite cumbersome, and it's honestly quite difficult. So given the relatively low incidence of cardiac arrest, it's probably impractical to train users frequently enough. One of the things I've been advocating for, which I think should happen and we should try out, is that I think the cardiac arrest team should be a series of 3 or 4 teams that rotate, and that way they're the experts and there are the local team that will always respond to the cardiac arrest. So obviously, the same team can't be on call 24 hours a day, 7 days a week, so splitting it up into 4 or 5 teams, I think, is probably the most appropriate solution. So overall, our study had several limitations. It's a single-center trial with relatively modest number of participants. The generalizability of our results to other defibrillator models is also uncertain. Obviously, I've mentioned my liking of AEDs, so this does not apply to automatic or automated external defibrillators and does not apply to other manual mode defibrillators. This is only for the one that we have at our institution. And obviously, our participants were recruited on a voluntary basis, raising the possibility of a selection bias. And what is the actual definition of difficulty? Obviously, this is very highly subjective and has not been externally validated in any sense. So, in summary, most of our participants in our study were unable to perform a defibrillation or a shock within 2 minutes. We suspect that this delay in defibrillation is at least partially a result of defibrillator design. And most people find it difficult to do, but there is that component of learning as well. So as long as you've got enough experience, I suspect that you can overcome the defibrillator design, but if you don't, then problems may arise. And here's just a list of my references.
Take questions.
Absolutely. Thank you very much, Kathy and Gianni, for those 2 presentations. We have had a few questions come in, and I'll just remind the audience, if there are any questions that you have for either of our presenters, please enter them into the chat box. We'll do our best to collect them and answer them with the remaining time that we have. The first question that came in was in regards to collecting qualitative data, and they're wondering what kind of questions you ask participants and if there are themes to the questions.
Yes, the basic questions that were asked we started off with very open-ended questions. So we would ask them basically, what part of the defibrillator did you find most challenging, or the task did you find most challenging? And then we opened it up from there. And as well, we asked more specific questions as you saw, basically, did you have any difficulty turning on the defibrillator, and did you have any difficulty attaching the pads? We also asked why you chose to use the pads versus the paddles. Do you know how to actually use the paddles was a question that I didn't put on my talk here, but I wanted to get a sense from the residents about why they're uncomfortable with using the paddles as opposed to the pads. So those were the general type of questions asked.
Great. Second question for yourself, Gianni. They ask, usability testing prior to purchasing equipment is not common within most smaller healthcare centers, and based on that, do you have any recommendations on how organizations could conduct low-fidelity simulation to evaluate equipment prior to purchase?
The December talk, actually, in the series is covering.
Yeah, what I would kind of suggest as well is I don't think you need to reinvent the wheel. I think what I've done plenty of times in terms of, so I've worked in multiple different ICUs, and I've used different products in different ICUs and have really enjoyed some of the products that have been in other ICUs. So basically what I would suggest people do is actually ask around and see what other institutions are using that they really enjoy it. And if they're willing to, I mean, someone like myself or Kathy, which we've done this before, is actually do some human factors, I guess, methods or tests, such as maybe FMEAs on the products, or actually potentially use it in a sim center before actually rolling it out. I think it can be easily done, especially with the intended end users. Like for instance, if it's I mean, you and I did this with an IV pump. Our hospital went to brand new IV pumps, and unfortunately there was no usability testing or FMEA results available to us. And what you can potentially do sometimes as well is actually ask the manufacturer for those tests if they have been done. Some manufacturers are a little bit more willing to share those results with you, at least on an offline basis sometimes. That's what I've noticed, depending on the type of product and I guess the amount of product that you're purchasing. But speaking to a rep from whatever company for whatever product, sometimes you can gain access to that information or ask them, do you mind if we take your product and test it out for a little bit? And they're usually pretty open to that.
I'd also like to add that, you know, when you learn more about what a good design looks like, it also helps you when you're going to evaluate, or even for clinicians who are asked to give their opinion on a piece of equipment or a piece of software. Once you've educated yourself a little bit about what a good design looks like, you'll be able to provide better feedback as well. And then the December talk in this series is going to be talking about procurement, and so that might also help.
Great. There actually was a question about some of the future topics in this.
Sorry, it's one of our announcements.
Oh, that's okay. There was a question about what some of the future webinars in this Human Factors series will cover. Specifically, someone was wondering if there's any content on human-to-human interaction and handoff tools.
Yes, there is. And off the top of my head, I can't remember which month has handoffs, but yes, there is going to be a webinar on handoffs, and there will be a list of all the webinars that will be on the website. But handoffs is coming up, and it's not me actually, it's physicians from Toronto who's going to be leading that, but I'll be on that call as well.
So as I mentioned at the top of the call, all of the webinars that are part of the Human Factors Call series, information about them will be posted on our website as it becomes available. Registration for the next webinar on October 18th is posted, and we have others scheduled November 15th and December 13th to start. Visit patientsafetyinstitute.ca to learn more. You can also subscribe for our mail out and be informed of these as they come up via email. There was a comment in the chat box saying that the defibrillator shown is an outdated model and that Philips had discontinued sales of that device in 2013 and that service and support ends in 2018. They went on to say that many of the design flaws outlined have actually been improved in newer models.
I'd say we're great. That's great to hear, actually.
Yeah. So I'm very happy to hear that. And I suspect, and I'm hoping that with our procurement of the new defibrillators, that these issues will hopefully be resolved, because currently, as you can see, there's definitely an issue with them. That doesn't surprise me at all, given the, I'll put this delicately, given the how far, I mean, the equipment that we tend to use here at the hospital, I'll say it's maybe not the most up-to-date equipment available to us. So obviously, the hospital tries as hard as it can to get the best equipment possible, but it's a long process, expensive process, and given the physical sort of situation, it can be difficult to keep everything, all the equipment up to date. But I'm very glad to hear that.
Actually, I'd just like to say that compared to, say, 20 years ago when I was in hospital environments, I used to see a lot more equipment that was from various manufacturers. And I think that there has been a trend in hospital procurement processes where the whole fleet of some piece of equipment is made redundant, and you are now just dealing with one product, because there's a lot of human factors issues related to having to go, excuse me, from unit to unit or from hospital campus to other hospital campus, and finding different equipment with different features, and the navigation is different. So, you know, when you have decided on a product and you are able to replace so that it's all the same product, assuming that the usability is good, because otherwise you end up with a whole fleet that does not have a lot of good usability. But there's a lot of benefit to not mixing and matching all the time.
We've had a couple questions come in regards to a manual defibrillator versus an AED. Someone's wondering if moving to AEDs exclusively is a possibility given their ease of use. And another person was wondering, are you providing information to Philips?
So with regards to the first question, my only experience with AEDs has been out of hospital. So unfortunately, I've been in situations where I've actually witnessed a cardiac arrest out of hospital, either at my gym or in the mall, and actually had to provide CPR and defibrillation. And my experience from those AEDs, as mentioned, has been excellent. I think there is, so I no longer participate in the resuscitation committee here at the hospital, the CPR committee. But the last meeting that I was at, there is talk of moving towards that. So I cannot comment on that completely. And with regards to the second question, which was, again, sorry.
Providing feedback to Philips.
Oh, yes, feedback has been provided to Philips, but not necessarily, it wasn't by myself, but someone has assured me that that information has been conveyed to them.
Great. We've got one final question that was submitted in to us. They're asking why the cables aren't connected to the defibrillator and ready to go, and that only when a decision is made to switch to hard paddle should you need to switch to therapy cables.
Yeah, again, this has to do with this is beyond my scope of knowledge in terms of engineering or electrical engineering, but the default setting, so what every defibrillator is actually connected to is a battery pack. And I don't know the reasoning for that. So you have to, the battery pack is connected to a similar cable. You have to remove that first, and then you have to attach the paddles or the pads. And I do not know why that is. I would have to probably speak to someone at Philips who designed the machine, but I'm not certain. And without that, the fear is that if the machine is not plugged in and charged, then the machine will not work, according to our defibrillator educators. So if that's not connected and charged, if you're at a code blue and require that machine, it would be non-functional.
Great. Thank you very much. I'm just taking a quick peek now through the Q&A and the chat box. I'm not seeing anything else. Oh, one more quick one here. You are able to get quite a reading with the paddle and not with the pads. Oh, perhaps a comment to your last response, Gianni.
Sorry, say that again.
So it reads, you are able to get a quiet reading with the paddle and not the pads.
Okay.
I just also wanted to kind of make a comment about, whether training is going to help or policies are going to help. And so I don't know if some of the participants have seen the hierarchy of effectiveness. And there's a Cafazo and St. Cyr article that has a good diagram in it of the hierarchy of effectiveness. And training helps, but when you're in a stressful situation, it doesn't necessarily come through. So if you can design the equipment and the systems that you're working in so that you can't actually make a mistake, and you see that, sort of in many designs where you cannot, plug something in to, sort of the wrong outlet or whatever, right? So, I mean, you can design so that you cannot make mistakes. And I think that that's, where you want to be headed. And I would say that, I see that manufacturers and healthcare professionals and organizations are working more closely together in terms of trying to reach the goal of complete patient safety. I mean, I think that's where we all want to go, including the manufacturers.
All right, that's great. On that note, I think we'll wrap up the call for today. Thank you, everyone, for joining. Before you log off, I'll ask that you please complete the poll that we have. Your feedback is very important to us in order to improve future calls. I'd like to thank our two presenters, Kathy and Gianni, and on behalf of my colleagues here at CPSI who helped put this on, Tricia Schwartz and Gina Peck, thank you very much, and have a great day.